Hi, I'm Dr. Joel Barton. I'm here to talk to you a little bit about selective tibial single shot and continuous quadriceps sparing femoral blocks. I want to talk to you about how and when to use them. Before I begin, I want to show that I have no conflicts of interest to disclose in relation to this presentation. My objectives, there are several for this lecture. I want to establish the benefit of a selective tibial block as well as review the relevant anatomy for both a selective tibial block and for a quadriceps sparing femoral block. I'll talk a little bit about the latest study for the selective tibial block as well as clinical applications for both of them. And the majority of this lecture is going to be talking about the approach for both the selective tibial single shot block and the continuous quadriceps sparing femoral block. It's a nuts and bolts lecture. But first of all, why would you want a selective tibial block? Well, posterior knee pain is an issue after total knee arthroplasty. It has been shown already that femoral and sciatic blocks give greater analgesia than femoral blocks alone in total knee arthroplasty. However, when you do a sciatic block, you can have foot drop. Not only that, but the posterior knee pain is often short-lived. If you place a sciatic catheter, many places remove that sciatic catheter on post-op day 1 because your post-op pain in the posterior knee has resolved at that time. Peroneal nerve palsy is not uncommon in total knee arthroplasty. It's a well-known complication, and if you block the peroneal nerve and there's an injury from the surgery itself, this can cause conflict both between you and your surgeon, you and the patient, and medical legal issues. It's been proposed, and I believe this last study demonstrates well, that the articular branches of the tibial nerve contribute more to posterior knee pain than the common peroneal nerve. In fact, the common peroneal nerve may not contribute anything of clinical significance at all. The anatomy hasn't changed in a long time. I'm using this because it is from 1918 and in the public domain. You can find color images if you want on many of the more common websites. But although the plates that we memorized are important, the ultrasound anatomy is where this becomes clinically relevant. So I want to discuss a little bit about the ultrasound anatomy for the popliteal fossa. This is your tibial nerve in the popliteal fossa. This is your popliteal vein and artery. And this is the common peroneal nerve. And in here, you may see the lateral geniculate artery in some patients. In some patients, it does not show up very well. The study that I want to talk about before we go into the nuts and bolts of how to do this is actually a study that was published in Anesthesia and Analgesia in 2012, although it was initially presented at IARS in 2010. I want to stress that this is not my work. I'm very grateful for Dr. Sinha and his colleagues who did the femoral nerve block with selective tibial nerve block study, showing that it provided effective analgesia without foot drop after total knee arthroplasty. This was an 80-patient observer blinded study of isolated tibial versus distal sciatic single-shot block, and they used continuous femoral catheters for the femoral pain fiber block. The primary outcome for this was actually to see whether they could do successful peroneal sparing. There have been studies before that showed that they were unable to successfully spare the peroneal nerve in a consistent manner. Secondary outcomes, however, were intraoperative narcotic needs as well as the pain score and opiate use, both in the PACU and then for the next 24 hours. So in this study, however, they were able to successfully have peroneal nerve sparing. You see, these are the types of the peroneal nerve blocks, either complete motor block, partial motor block, or sensory block. And for the selective tibial, they had 0% complete motor block with their technique for a tibial block. They did have some partial motor block, but this still allows for monitoring of the common peroneal nerve. Afterwards, if you have a peroneal nerve palsy from surgery, you're unlikely to have only a partial block. It's much more likely to be a complete block. In their distal sciatic, they did have a complete motor block, 82.5%, and a partial motor block, 12.5% of the time, for a total of 95% motor block with their distal sciatic nerve block. Their secondary outcomes, however, were all equivalent. They used the same amount of intraoperative narcotics. Their pain scores in PACU and their 24-hour pain scores were equivalent, and their opiate consumption was equivalent both in PACU and for the next 24 hours. The rebolusing the femoral catheter was also equivalent. You can regard this as an internal check for the study because the femoral catheter rebolusing should have nothing to do with whether or not they block the peroneal nerve in the sciatic distribution. There are some limitations to this study. It was a very important study, and I think that it's important to follow up on it. However, it is not a comparison with higher sciatic nerve block or a continuous sciatic block. They use different volumes of local anesthetic at the tibial and the sciatic sites. This makes sense. The tibial nerve has a smaller circumference than the sciatic nerve, and therefore to adequately halo the tibial nerve, you would need less volume. You may need more than 80 patients, however, to prove secondary endpoints. Their power calculations were for their primary endpoint, which was whether or not they could successfully block the tibial and isolate that from the peroneal nerve. They used multimodal analgesia, and their pain scores were relatively low on both sides of the equation. There are other studies going on, including one out of Texas Tech, and I think that it would be valuable to take these other studies and combine all the data into a meta-analysis so we might have a more firm number as to whether or not this is truly equivalent. So there is more work that needs to be done. They did have a lower success rate for tibial block than in other studies, but they used a lower concentration. They used 0.5% ropivacaine instead of 0.75. And they used no adjuvants, whereas the other one used epinephrine in the mix. Their exclusion criteria was fairly strict, so broader applicability, say for a patient with diabetes and diabetic neuropathy, is not yet there. However, this study does provide an ethical basis by which you can expand your exclusion criteria in further studies. I'm not going to talk a whole lot about the studies, but I did want to at least mention that there is work being done on this. The selective tibial block, we all know the anatomy. This is the semimembranosus and semitendinosus muscles. Here's the gracilis. Below that is the insertion of the adductor magnus. And then classically, in all our plates, you see the popliteal artery, the popliteal vein, then the tibial nerve, then the common peroneal nerve, going from medial to lateral. And then you have biceps femoris and vastus lateralis in the IT band, or the iliotibial tract there. There is a medial approach and a lateral approach to this. With the medial approach, it's most often done with the patient in the prone position for the block. The muscles, as I said, are the semimembranosus, semitendinosus, the gracilis, and the insertion of the adductor magnus. The lateral approach is what I normally use. It's a little more versatile as far as patient positioning. You can do it with the patient in the prone, lateral, or the sitting position with their leg propped up. The muscles and tendons are the biceps femoris here, and the vastus lateralis, and the iliotibial tract is a band of fascia there in the middle of those. And it's important to note that the common peroneal will be seen first in the lateral approach. However, it is both superficial and lateral to the tibial nerve. The medial approach has already been published in a video on blockjocks.com with Dr. Brandon Winchester. If you pause your screen here, you can either copy or click on the link below. The lateral approach, again, I want to use the ultrasound anatomy because that's what you're going to be seeing when you start this with a patient. I generally begin with the patient in the lateral position, and for total knee arthroplasty, I'll do the tibial nerve block first and then proceed on to the femoral nerve block. That gives time for your tibial nerve block to set up, and then you can document the preservation of peroneal function. But begin with the patient in the lateral position in the popliteal fossa. Visualize both your vein, your artery and your vein, and your tibial nerve here, and your common peroneal nerve here. Be aware of the structures, both the one that is your target here, and also the ones that you don't want to hit. If you scan up to the distal sciatic nerve and then back down, you want to follow the sheath. This is tibial nerve and this is peroneal nerve. And when you scan, you can see that there's still a sheath connecting these two. And if you block your tibial nerve here, the local anesthetic is going to track along that sheath, and you're going to get a peroneal nerve block as well. So make sure they're very separate. See how the two are separate here? The peroneal nerve is over here. The tibial nerve is over here. You have vein, artery. There's actually an accessory vein right here as well. And so you have to be aware of the structures that are there, and you have to make sure that the two are separate. This is a good place to do your block. It needs to be at least above the halfway point of the popliteal fossa as well to have adequate analgesia. For the lateral approach, I use 2% lidocaine and insert it under direct visualization. This slide is to show you where the insertion point should be. When you look at your screen, this is the peroneal nerve here, and that's at about 1/2 centimeter. Your tibial nerve is here. You're aware of vascular structures. And your tibial nerve begins at about 1/2 centimeter and extends down to 1.25 or 1.3 centimeters. When you enter, and you're choosing your insertion point, you need to enter here instead of here, because you don't want to enter at the level of the peroneal nerve. If you enter deep to the peroneal nerve, you decrease your risk of peroneal nerve injury, but you also optimize your echogenicity of your needle because it'll be 90 degrees to your echo probe, which is going to be having a plane coming down this way, and your needle is going to be going in this way. So therefore, you're 90 degrees and you get your optimal return from your needle. When you're looking on the leg, it's going to look something like this. Notice the probe is here, but the markings for the ruler start in a little bit because you're depressing the probe. And so your vastus lateralis and your biceps femoris tendon may actually be beyond the tip of the probe. So 1.33 centimeters or 1.25 centimeters is right here. This would be your insertion point for your needle. Do not start near the probe because that is where your peroneal nerve is. You put 2% lidocaine in the IT band and also in the biceps femoris under direct visualization. Again, I cannot stress enough, do not go close to your probe. Choose your depth based on the depth of your tibial nerve. I would build something into your process so that after you place the 2% lidocaine, you can then either set up your needle for your nerve block or draw something up so that you have 15 to 20 seconds for your 2% lidocaine to actually set up, instead of putting the lidocaine then immediately going with the nerve block. So your patients will appreciate that. This is an overview of what we're going to talk about in the next few slides. For the lateral tibial nerve block, I use a 4-inch short bevel needle. Do not use a sharp needle near the nerves. The first 2 milliliters of 0.5% ropivacaine should go between the tibial nerve and the vascular structures. This affords you a degree of safety by pushing your nerve up and towards your probe and pushing your vascular structures down and away from your probe and away from your needle. Then place the needle tip at the margin of the infiltrate, and I'll have a slide to illustrate this next, to facilitate the halo of that tibial nerve. I use a total of 6 milliliters of 0.5% ropivacaine. This usually lasts me in the order of 8 hours postoperatively. And by that time, as it wears off, there's a very small increase in their overall pain. Again, proceed to the femoral nerve block after you've done the tibial nerve block, and then assess peroneal nerve function when you have completed your femoral nerve block and document. If you do not document peroneal nerve function, this is all in vain. You need to document it for medical legal reasons. So this is the insertion site. You can see the needle coming in. I began a little deeper than 1.2 or 1.3, so there's a little bit of an angle, but you still have great echogenicity on the needle. And you come in well away from the peroneal nerve. The peroneal nerve is up here. And insert at the border of your vascular structure. Remember the vein was here, and your tibial nerve. And you come in right at that corner. This is 2 milliliters. At 2 milliliters, you've pushed the nerve up and away from the vascular structures. And because of the echogenicity of the needle, you get a little bit of artifact here. It's hard to see, but your vessel border is here. And so there's more space. After 2 milliliters in, adjust your needle so that it is in the corner of your infiltrate. This will allow you to direct the stream and assist in hydrodissecting the nerve away from the fascial planes, which means that you'll have a faster and more even setup. At 4 milliliters, you then have hydrodissected more of your nerve away, and you've covered approximately 2/3 of the circumference of the nerve itself. Once again, adjust your needle for the 6 milliliter, the last two, for a total of 6 milliliters. If you cannot achieve this angle and at this corner, you can always pull your needle back and come in straight and insert in here in the sheath just above the tibial nerve. And then the 6 milliliters will allow you to fully halo the nerve so that the top third is covered. It's hard to see because of the artifact. However, there is local anesthetic that halos the entire nerve at this point, and we've maintained ourselves with vascular integrity, and we haven't affected our peroneal nerve at all. There are clinical applications for this. There's both the total knee arthroplasty. For the majority of the total knee arthroplasties that I do a continuous femoral block as well as a selective tibial single shot block. And I also do selective tibial single shot blocks for things such as ACL repair or tibial transfers. For the ACL repair, I do both a selective tibial single shot block and a continuous quadriceps sparing femoral block and send them home with a disposable infusion catheter. I will talk a little bit about the quadriceps sparing femoral block. However, before I do that, I just want to review about selective tibial single shot blocks. So, in review, the sensory input at the knee is femoral for the majority of it. However, there are articular branches that come from both the tibial and the common peroneal. However, the common peroneal articular branches that go to the knee do not seem to have a large degree of clinical significance, and therefore it's possible to spare the common peroneal and still have satisfactory analgesia. Selective tibial block is both possible and is equivalent to a distal sciatic block in pain control and opiate consumption in the next 24 hours after surgery. There are some limitations, however, to the studies that have been done. You may still get some peroneal block. You'll have a partial block. This still allows you to monitor peroneal nerve function, but you may have some weakness in dorsiflexion at the ankle. It's also uncertain as to whether this compares to high sciatics or continuous sciatic blocks. The performance of the block does require ultrasound. You cannot do this with stim alone You have to be able to see the peroneal nerve. You have to be able to see the tibial nerve. You have to be able to see the vascular structures. You have to be able to see where your anesthetic is going. This also requires a low volume of local anesthetic. If you use a high volume, it's going to track back along the tibial nerve, and you're going to get a complete peroneal nerve block anyway, and you might as well have done a sciatic nerve block. It does have implications for physical therapy, both in terms of analgesia. You'll be able to work better because you have less pain with the movement of the knee, but also with a tibial block, you'll have numbness at the sole of the foot for a couple hours after surgery. You're blocking the sensory dermatome as well, and so you should expect that and tell the patient about it, so that when they first place their foot down, they need to watch where they put their foot. They'll have sensation, they'll be able to feel pressure, but it'll feel numb and a little bit tingly, kind of like the bottom of their foot's asleep, and they need to be aware of that. There are medical legal implications for this too. If there's damage such as a peroneal nerve palsy after total knee arthroplasty, and you've documented that your block did not affect the peroneal nerve, then that would afford you a degree of safety afterwards in any sort of a court of law. So, moving on to quadriceps sparing femoral blocks. This is also called an adductor canal block. There's relevant anatomy. We're going to go through this in the ultrasound scans and talk about the various muscles, the vasculature, and the nerves. You can read this for yourself. We're going to go on to the scan though. In the scan, initial scan, this is looking at mid-thigh with the sartorius muscle here. This is your adductor canal, this triangle here, and it's bounded by the sartorius muscle on the top or superficially, the adductor magnus medially, and the vastus medialis laterally. In here you'll have the superficial femoral artery, which used to be called the femoral artery after it split from the deep artery of the thigh, but for sake of this talk will be the superficial femoral artery. It also has the distal branch of the femoral nerve, which will be the saphenous and also penetrators going into the vastus medialis. If you scan along the sartorius and visualize the nerves from the distal femoral penetrating the vastus medialis, this will tell you where you need to do your block. So if you look at this scan, you can see the beginning of a penetrating nerve going to the vastus medialis from your femoral nerve. There's going to be nerve tissue on both sides of the vascular structure. This is usually artifact just because of the change in contrast. So this is not nerve. So there's one right there, and you can see it going out. And then here's another major contributor right there. So I go below these. Look for them. If you can't find them, it's not the end of the world, and I'll talk to you about where to place this if you don't see any major contributors, but you should look for them in the interest of avoiding them later on. If you're going to look for this, your block will be between the junction of the proximal and mid-third of the thigh. So if you divide the thigh into thirds, the proximal and mid-third, you find that point on the leg and then the midpoint of the thigh. So it should be somewhere between the first third and the halfway point in the thigh if you cannot find any penetrator going to the vastus medialis or you have a poor picture for reasons of probe, machine, or patient. Once the site is chosen, rotate the probe 45 degrees or more to allow more proximal insertion site. The insertion site is here. It's not here. Even though you're normally scanning, you're going to be 90 degrees to the femur. This does a couple things. It gets your insertion site out from under the tourniquet and further from the surgical field. Your surgeon will thank you. They also won't rip out your catheter when they take the dressings off. And it means it's also not under the tourniquet, and you'll hear less about that as well. I usually use a 4-inch needle for this. Try to maximize and get a full 10 centimeters from here to where you're doing your block, or as close to it as possible. This will give you a more proximal insertion site, and your surgeon will thank you, or at least won't yell at you. This is the difference between the scanning view and the insertion view. Realize when you're scanning, you're 90 degrees to the femur, you're going to have nice circular vessels, and it's going to look very clean. When you rotate it, your view is going to change, and you have to conceptualize the fact that you're going to cross-cut on your vessels. They're going to be ovoid instead. This is still nerve. This is still sartorius. These are still your blood vessels. This is still vastus medialis. It's just going to look a little bit different. You have to realize that when you're considering your site picture. I again use 2% lidocaine. It gives a much better block than 1%. I use a 2 to 3 inch 25 gauge needle to anesthetize the insertion tract. And do this under direct visualization. You don't want to poke the nerves you're going for with a sharp needle. Be sure to place the majority both at the skin and then at the fascial planes you pass through. These are much more painful than passing through the muscle bodies, but you do need some in the muscle body as well. The view for local infiltration, at this point, your adductor canal, this is the corner of your adductor canal here. It actually extends beyond the screen here, and this is your sartorius muscle. You're going for the very edge of the sartorius muscle, and your insertion point for your lidocaine, this is a 25 gauge needle coming in. You come in, get the corner of the sartorius muscle, and begin to enter the plane between the sartorius and the vastus medialis. This is actually a neurovascular bundle and probably one of those penetrators we were looking at earlier. The entry into the plane for lidocaine looks like this. I go above, and then I'll pop through that little fascial plane. You can see the change in the tissue, and that's because you have a little bit of increased resistance as you go through a fascial plane. Put lidocaine on both sides of that. And then extend along the plane, going towards your adductor canal. Again, here's your adductor canal. You're going to extend along this plane. So this is your 25 gauge needle, and this is about as far as you need to go. Don't go all the way to your nerve. If you put local anesthetic here, it will track along that plane, so that when you go through with your 17 gauge TUI, they won't have the same words for you they would have otherwise. And this is the lateral margin. Go all the way to the lateral margin with your hydrodissection of your local anesthetic, but don't take your sharp needle here. Then insert your 17 gauge TUI along that same plane. Here's the tip of the 17 gauge TUI going to the lateral margin. In the next few slides, we're going to talk about how you do the infiltration for the quadriceps sparing femoral block. First, hydrodissect from this lateral margin of the adductor canal to the vascular margin. I used about approximately 5 cc's of fluid to get from point A, here, the lateral margin, to point B, the vascular margin. At the vascular margin, deposit the remainder of your first 5 cc's there, and then place your catheter in the corner here. And you'll see that in the next slide. And hydrodissect the plane between the vasculature and the fascial plane, separating the sartorius and the vasculature in the adductor canal. Then deposit the remainder of a total of 10 cc's of 0.5% ropivacaine on the opposite side and thread your catheter. Don't use more than 10 cc's. Again, you'll track back up the adductor canal, and you're more likely to get no quad sparing whatsoever, and then they won't be able to lift their quad and they won't be able to go home. So this is after hydrodissection from the lateral margin to the vascular margin. This is the beginning of your vasculature, again, with a bright needle image because it's fairly flat in this plane. You're going to have some artifacts. You may no longer see your nerve tissue as well, but it's right here. And then hydrodissect between your vasculature and the fascial plane for your sartorius nerve. This will give you space to then move your catheter along safely so that you do not endanger either penetrating the vasculature or leaving your adductor canal and not having a block. Once you have gone past the vasculature and deposited the remainder of your 10 cc's, place the catheter there so it drapes over the femoral artery. Your local anesthetic, wherever you place a catheter, is going to track back along your catheter. You know this because if you don't put a little bit of dermabond at the site where your catheter enters, it leaks like a sieve. The hole is always bigger than the plug. The needle has to be bigger than the catheter, and so local anesthetic will track back. If you can make it out of the skin, it's going to make it back a couple centimeters over a few blood vessels that you've opened up by dissecting along with your fluid. If you look at this, you can see that is both the artery, and then the full color is when I injected fluid through the catheter. However, it's fairly imprecise to use color to find exactly where your catheter is. So another way of doing it, and what I prefer better, is to actually use air. So in end result, this is the insertion view. This is why they look slightly ovoid. Here's the catheter. You see that bright line right there? Going over and onto the opposite side. Here's your sartorius muscle. When you inject air, you can see the air goes along the catheter and is on both sides of your vessels, so you're much more likely to have a full, complete block in the adductor canal. At the end, the important reason that I stress the pathway is because your catheter is going to follow wherever your needle was. And so you need to place your needle where you want your catheter. When you're doing your scan, this is the catheter coming in along the plane just below the sartorius. This is your adductor canal. These are the vasculature. So this is the lateral margin. It's entering in at the lateral margin. It's going right over all this nerve tissue. It passes along, you can see it here, passing along over the vasculature, and then it goes on to the opposite side as was seen in the previous scan. If you do not put your needle where you want your catheter will never end up where it's supposed to be. At the end, put a little bit of dermabond at the entry site. I know this increases your unit price for any given block. However, it is wonderful for decreasing your risk of your leaking for patients going home. They won't have a wet catheter site. It'll decrease your calls at night as well, and your patients have more satisfaction with the block. Place an occlusive dressing at the site, but then take the catheter and bring it proximally and coil it just below the underwire line. If you put it under their underwear, it's both going to roll on the dressing, and your dressing will either come off or it's going to irritate them enough that they're going to complain about it and or take it out. It also means that you're less likely to have migration of your catheter both between the dermabond and having it tunneled approximately 10 centimeters. I run the catheter with 0.2% ropivacaine at 8 milliliters an hour. and I discharge them home with a disposable infusion pump. I know that the infusion pump people tell you not to take, not to leave the key in so that they can adjust it. However, I found it more useful in responsible patients to leave that key in and discuss with them on daily calls whether or not they need to go up on the pump or down on the rate of the pump. If they have quadriceps weakness, you can always go down on the rate of the pump. Whereas if you have room to go up, you can always try it and tell them if they develop weakness that they can go down. There are issues with this in falling, so you can do this at your own recognizance. 62.5 hours is the rate, is the duration of a pump running at 8 milliliters an hour with 500 cc's in it. So the patient will remove their catheter at home after 62.5 hours. Our average pain scores for ACLs for the last 62.5 hours have been between a 1 and a 3 out of 10 with high degree of patient satisfaction. Thank you very much for giving me this opportunity to discuss both selective tibial single shot blocks as well as continuous quad sparing femoral blocks.